Fetal growth restriction, FGR. This presentation will include definition, etiology, detection, risk factors, evaluation, management during pregnancy and intrapartum, complications, and how to prevent in subsequent pregnancy. Starting with definition, there are two different definitions, one from ACOG guidelines and the other from RCOG guidelines. ACOG define FGR as estimated fetal weight or abdominal circumference less than 10th percentile for gestational age. This should be differentiated from another terminology known as small for gestational age, SGA. It is a postnatal definition defined as a newborn birth weight less than 10th percentile for gestational age. One problem with this definition is that about 70% of fetuses diagnosed as FGR, according to this definition, actually they are not FGR. Instead, they are small but healthy. We call them constitutionally small fetus. For this reason, RCOG has a different definition. When the estimated fetal weight or abdominal circumference less than 10th percentile, it is called small for gestational age fetus, SGA fetus. When it becomes less than the 3rd percentile, it is considered severe SGA. While fetal growth restriction, FGR, is a pathological restriction of the genetic growth potential. Etiology of FGR may be maternal, fetal, or placental. Maternal causes include hypertensive disease, pregestational diabetes, cyanotic cardiac disease, autoimmune disease, restrictive pulmonary disease, high attitude, tobacco or substance abuse, malabsorptive disease, multiple gestation. Fetal causes include teratogenic exposure, fetal infection, genetic disorders, structural abnormalities. While placental causes include primary placental disease, placental abruption, placenta brevia, and placental mosaicism. How to detect a small fetus? Now I will discuss the methods of assessment and how to choose a method for assessment. Actually, there are two methods to assess fetal growth. Number one is symphysial fundal height measurements, and the second method is ultrasound biometry. Regarding symphysial fundal height measurements, it measures the distance from the symphysis pubis till the top of the uterine fundus. The measurements in centimeters approximate gestational age in weeks. I mean, at 28 weeks, we expect symphysial fundal height to be approximately 28 centimeters. And the fetus is considered small if the measurements differ by 3 centimeters or more. I mean, at 28 weeks, the symphysial fundal height is 25 centimeters or less. This is considered a small fetus, and the sonography is generally performed. However, symphysial fundal height has limitations. It has a poor sensitivity, with detection rate of 11 to 25%. Also, the detection rate is lower in obese women. Now, how to choose a method between symphysial fundal height or ultrasound to monitor fetal growth. Actually, this depends on risk assessment. I mean, at the booking visit, we will ask about risk factors, and the patient is categorized into either low risk or high risk. Low risk cases, fetus is monitored with symphysial fundal height measurement starting from 24 weeks, while high risk women, we monitor fetal growth by ultrasound for biometry and umbilical artery Doppler starting from 26 weeks. To perform a risk assessment, this depends on risk factors. This algorithm from Green Top Guideline starts risk assessment at the first trimester and classifies risk factors into minor risk factors and major risk factors. If there is one major risk factor, the patient is considered high risk, and fetal growth is monitored with ultrasound for biometry and umbilical artery Doppler starting from 26 weeks. On the other hand, if the patient has 3 or more minor risk factors, these are not enough to consider the patient high risk. We need a further risk factor. For this reason, we perform a uterine artery Doppler at 20 to 24 weeks. If uterine artery Doppler is abnormal, the patient is considered high risk, and fetal growth is monitored with ultrasound starting from 26 weeks. While if uterine artery Doppler is normal, we assess fetal size and umbilical artery Doppler in the 3rd trimester. What are the major risk factors? This includes personal and social factors, such as maternal age more than 40 years, smoker more than 11 cigarettes per day, cocaine use, daily vigorous exercise, paternal SGA, or maternal SGA. Regarding obstetric history, previous SGA baby or previous stillbirth. Regarding medical disorders, chronic hypertension, diabetes with vascular disease, renal impairment, antiphospholipid syndrome, and the problems during current pregnancy includes heavy bleeding similar to menses, and pregnancy-associated plasma protein A, known as PAP-A, become less than 0.4 multiple of median. PAP-A is a marker used during combined screening for Down syndrome. And one element in the 2nd trimester anomaly scan is fetal echogenic bowel. In some women, it is unsuitable to monitor growth by symphysis fundal height measurements. These include large fibroid and BMI more than 35. In these conditions, fetal growth is monitored with ultrasound biometry and umbilical artery Doppler starting from 26 weeks. Regarding minor risk factors, these include social and personal history, such as maternal age more than 35 years, smoker but less than 11 cigarettes per day, and low fruit intake pre-pregnancy. Obstetric history includes IVF singleton pregnancy, nulliparity, previous preeclampsia, and the pregnancy interval less than 6 months or more than 60 months. During assessment of BMI, if it is less than 20 or between 20 and 25 and 35, it is considered a minor risk factor. To remember the uterine artery Doppler, during the 1st trimester, the uterine artery Doppler has a low end-diastolic flow and early diastolic notch. With advancing pregnancy and remodeling of the spiral arteries, the end-diastolic flow will increase. And during late 2nd and 3rd trimester, the end-diastolic flow will become high and early diastolic notch will disappear. Uterine artery Doppler is considered abnormal if PI more than 95th centile or the presence of notching. Evaluation of the small fetus involves confirmation of the diagnosis and finding the etiology. If the fetus is small, I mean the fetus is less than 10th percentile for gestational age, we monitor fetal growth and fetal physiology over time. By fetal growth, we mean measurement of gestational age, and the fetal physiology means measurement of umbilical artery Doppler and the amniotic fluid assessment. The fetus is considered constitutionally small if there is normal growth curve, normal umbilical artery Doppler, and the normal amniotic fluid volume. Regarding the etiology, history and examination, it assesses for maternal disorders associated with FGR, such as preeclampsia, for example. Fetal anatomic survey is important as about 10% of FGR fetuses is accompanied by congenital anomalies such as omphalocele, gastroschisis, diaphragmatic hernia, skeletal dysplasia, and some congenital heart defects. Fetal genetic studies is indicated in any of the following if FGR is early, I mean less than 24 weeks. Severe FGR, it is considered either less than 5 or 3 centiles. Symmetrical FGR, I mean both the head of the fetus and the abdomen are decreased. Major fetal structural abnormalities and the presence of soft markers in ultrasound such as thickened nuchal folds or choroid plexus cyst. Workup for infection is important. Maternal serum for seropositivity if infection is suspected clinically. This includes assessment for cytomegalovirus, toxoplasmosis, rubella, and varicella. Screening for inherited thrombophilia is not recommended, as evidence for an association between inherited thrombophilia and FGR is weak. During management of FGR, if the condition is associated with congenital anomalies or chromosomal abnormalities, management depends on the specific abnormality. For other cases, management options include fetal monitoring, antenatal steroids, maternal interventions, and delivery. Fetal monitoring, firstly, is it outpatient or inpatient? Most cases of FGR are usually monitored as outpatients. However, hospitalization is considered for selected women who require monitoring every day, either for maternal or fetal assessment. For example, if the fetus has reversed in diastolic flow on umbilical artery doppler, daily biophysical profile assessment is required. For this reason, the patient should be admitted. Regarding gross scans, serial ultrasound is performed every 2 to 4 weeks to ascertain gross velocity. The estimated fetal weight is plotted either on a population-based chart or a customized gross curve. If there is a persistent gross deficiency in multiple examinations, this supports the likelihood of FGR. On the other hand, normal gross velocity in a small fetus suggests the possibility of a constitutionally small fetus. I mean small fetus but healthy. Umbilical artery doppler is the primary surveillance tool for monitoring pregnancies in which FGR is suspected. Abnormal umbilical artery doppler is defined as pulsatility index more than 95th percentile, or the presence of absent or reversed in diastolic flow. This graph illustrates the 4 categories of umbilical artery doppler. In category A, this is a normal waveform with normal SD ratio. Here you can see the systole, and at the end of the cycle, this is the end diastole. As you see, the diastolic part is high because the spiral arterioles have a low resistance. And so the SD ratio is low, and also pulsatility index and resistance index. In the second graph, the end diastolic flow decreases, and consequently SD ratio and other indices will increase. In the third graph, the end diastolic flow is absent. This is called absent end diastolic flow. And in the last graph, the end diastolic flow is reversed. So we have 4 categories: either normal umbilical artery doppler, increased impedance resulted in elevated umbilical artery doppler indices, absent end diastolic flow, and reversed end diastolic flow. If umbilical artery doppler is normal, perform Doppler at 2 weeks intervals, especially if the estimated fetal weight more than 5th percentile, there is normal gross velocity, normal amniotic fluid, and no maternal risk factor for placental dysfunction. In the second category, I mean the diastolic flow is present but decreased, perform umbilical artery doppler every week. aiming to detect progression to absent or reversed in diastolic flow. If the end-diastolic flow is absent or reversed, delivery should be considered. However, the decision to deliver in this setting is based on gestational age, non-stress test or biophysical profile testing, and ductus venosus Doppler. Another important artery to examine by Doppler study is the middle cerebral artery Doppler. And the aim is to detect a brain-sparing effect. With progressive hypoxia, blood flow to the fetal brain will increase to compensate for the reduction in the available oxygen. And this results in a reduction in the Doppler parameters in the middle cerebral artery. I mean a reduction in the SD ratio, RI, and PI. However, subsequent normalization of the indices may occur when the autoregulatory response becomes dysfunctional or lost. And one method to detect a brain-sparing effect is to measure cerebroplacental ratio, CPR. CPR is the middle cerebral artery pulsatility index divided by umbilical artery pulsatility index. I mean, we can measure the pulsatility index or resistance index. A reduction in the CPR indicates a brain-sparing effect. But what is the benefit of middle cerebral artery Doppler? In fact, there is no convincing evidence that middle cerebral artery Doppler alone is useful in the clinical decision about timing of delivery. It depends mainly on the umbilical artery Doppler. However, the middle cerebral artery Doppler is useful if combined with the umbilical artery Doppler in assessment of severity of hypoxia and also prediction of neonatal outcome. The third important vessel to examine by Doppler is ductus venosus. As you see, the ductus venosus Doppler. Each cycle of the ductus venosus Doppler is formed of three waves, I mean S, D, and A. S represent ventricular systole, D represent early diastole, while A wave represent atrial contraction. And the ductus venosus Doppler is considered abnormal if the A wave is absent or reversed. Regarding interpretation of the ductus venosus Doppler, if the ductus venosus Doppler is abnormal, I mean there is absent or reversed A wave, this is a sign of impending acidemia and death. And each day of such an abnormality in the Doppler doubles the risk of stillbirth. On the other hand, in a case of absent or reversed end-diastolic flow in the umbilical artery Doppler, if there is a normal ductus venosus Doppler, in addition to normal non-stress test and biophysical profile, this supports the decision to extend the pregnancy to 32 to 34 weeks, up to 32 if there is reversed end-diastolic flow, and up to 34 if there is absent end-diastolic flow, as we will discuss in the timing of delivery. Fetal monitoring using non-stress test and biophysical profile. We can use either non-stress test with amniotic fluid volume determination or biophysical profile or a combination of both to assess the fetal well-being. Regarding the frequency of this monitoring, it may not be required if the Doppler indices are normal, growth velocity is normal, and there are no risk factors for uteroplacental insufficiency and no signs of uteroplacental insufficiency. Twice per week assessment if there is oligohydramnios, preeclampsia, decelerating fetal growth, severe growth restriction, or increasing umbilical artery Doppler index. And this assessment is required every day if there is absent or reversed end-diastolic flow in umbilical artery Doppler assessment. Now we finished fetal monitoring. Regarding antenatal steroids, administer one course of antenatal corticosteroids between 24 and 34 weeks of gestation in the week before delivery is expected. Is there maternal intervention to improve the fetal growth in a growth-restricted fetus? Actually, many interventions have been tried, such as low-dose aspirin, bed rest, anticoagulation, oxygen therapy, and the plasma volume expander. But what about the evidence regarding these interventions? There is no convincing evidence that any intervention in a healthy woman improves the growth of a growth-restricted fetus. However, the use of phosphodiesterase 5 enzyme inhibitors, sildenafil, it appears promising, however, it's still under investigation. And definitely smoking cessation program may be of value. Appropriate timing of delivery is an important part in the management of fetal growth-restricted fetus. Immediate delivery is recommended in the following condition: the presence of abnormal ductus venosus at any gestation, the presence of reversed end-diastolic flow in umbilical artery doppler from 32 weeks, or the presence of absent end-diastolic flow in umbilical artery doppler from 34 weeks. In these conditions, immediate delivery is recommended. If there is a reversed end-diastolic flow less than 32 weeks, or absent diastolic flow less than 34 weeks, in these conditions, it is important to prolong pregnancy. So perform a daily biophysical profile in an attempt to delay delivery until 32 weeks if there is reversed flow, or up to 34 weeks if there is absent flow. However, if the biophysical profile or ductus venosus Doppler become abnormal at any time, immediate delivery is recommended. And of course, start a course of antenatal corticosteroid if it has not been administered yet. If there is a decreased diastolic flow, the pulsatility index become more than 95th percentile. In this condition, perform a biophysical profile 2 times per week and deliver the fetus at term. At term, at 37 to 38 weeks. Or when the biophysical profile becomes abnormal. If there is a normal umbilical artery doppler, deliver the fetus at 39 to 40 weeks of gestation, but delivery should not be delayed beyond 40 weeks of gestation. Regarding mode of delivery, unfavorable cervix is not a reason to avoid induction, and prostaglandin or balloon catheter can be used for cervical ripening. During labor, intrapartum care includes continuous CTG, provide a skilled neonatal care in the delivery room, and umbilical cord blood gas should be considered to establish a baseline neonatal status. If the fetus is less than 32 weeks, magnesium sulfate is given before delivery for neuroprotection. Complications associated with fetal growth restriction may be perinatal, long-term, or maternal complications. There is an increased risk of stillbirth, neonatal death, neonatal morbidity, and abnormal neurodevelopmental outcome. And the prognosis worsens with early onset FGR and increasing severity of FGR. On the long term, there is an increased risk of development of obesity, metabolic dysfunction, type 2 diabetes, and the cardiovascular and renal disease. Regarding maternal complication, The birth of a newborn with idiopathic growth restriction may be predictive of an increased long-term maternal risk of ischemic heart disease. In subsequent pregnancies, the risk of recurrence estimated in certain studies to be about 23%. And uteroplacental insufficiency may manifest in different ways. It may manifest as growth restriction, preterm delivery, preeclampsia, abruption, and stillbirth. During antenatal care, accurate dating of pregnancy by early ultrasound is important, and serial ultrasound examination to monitor fetal growth is also important. If the fetal growth is normal, FGR in a previous pregnancy is not an indication for antepartum fetal monitoring with non-stress test, biophysical profile, or umbilical artery Doppler. As a preventive measure, correct any potentially treatable cause of FGR, such as cessation of smoking. Avoid short or long interpregnancy interval. And low-dose aspirin if FGR was secondary to a preeclampsia. However, evidence does not support the use of the following: anticoagulation with unfractionated heparin or low molecular weight heparin, dietary changes and supplements, or bed rest. Thank you.